यार दीपक, वहां पे तो यार आईटी वालों की मीटिंग है कोई।
Good afternoon, everyone. We will start at 2:10. We have not started yet.
Hello.
So a very good afternoon to all. I hope I am audible. Okay, so on behalf of Quality and Patient Safety Division NHSRC, myself, Dr. Abhidaya, Senior Consultant with Quality and Patient Safety Division, National Health System Resource Center, welcome you all to this particularly important webinar series that we are conducting for implementation, providing support to the states for the implementation of National Quality Assurance Standards across the all level of the healthcare facilities. Earlier, we were conducting these webinar sessions for particularly inclined towards the primary healthcare facilities, but this time we have decided that these sessions will cover all the standards for each level of the healthcare facilities, and we will be talking about the standard requirements, what are how they need to be implemented at right from district level hospitals to the Ayushman Arogya Mandir sub health centers. So for today's, we have lined up two important topics. These are related to area of concern G and area of concern H. The first topic I will be covering on this particular lines is related to area of concern G. That is one of the core area of concern under the 8 area of concerns that we have under so as you all are aware, under NQAS we have 8 area of concerns. One is service provision, which is talking about the availability of the services at the healthcare facilities. Then the second standard, that is area of concern, that is related to the patient rights, which talks about the various components of accessibility, information to the patients, and the affordability of the services that are being provided by the healthcare organization. Third area of concern talks about the inputs, that is related to the availability of the infrastructure, HR, drugs, consumables. Then support services is the fourth area of concern, that is area of concern D, which talks about the availability and the functionality of the support services in a healthcare facility. Area of concern E talks about the clinical services, how they will be implemented as per the National Quality Assurance Standards requirements. Area of concern F is related to the infection control and the biomedical waste management practices that are needed to be implemented to meet the quality standard requirements. And then the two area of concerns we will be briefing you about is related to the quality management and the outcome indicators. So to start with, the under area of concern G, that is quality management. This is the overall measurement system for the particularly international quality assurance standards. Under district hospitals, we have total eight area of concerns for each level of the facilities. At district hospital, we have 75 standards. There are total 380 measurable elements and 21 departmental checklists. At the CHC level, we have similarly 8 area of concerns, the 65 set of standards, 297 measurable elements, and 12 departmental checklists. At the PHC level, again, the area of concern numbers remain the same. Again, the area of concern number remains the same. The standards are 50. There are 250, measurable elements, and there are 6 departmental checklists. At UPHC level, we have 8 area of concerns. There are set of 35 standards, 200 measurable elements, and there are 12 thematic checklists at the UPHC level. When we are talking about Ayushman Arogya Mandir sub-health centers, there are total 8 area of concern. Standards for the type A facility, that are the non-delivery points, are 48. And for the delivery points, Ayushman Arogya Mandir sub-health centers, we have total set of 50 standards. Subsequently, there are 124 measurable elements at Ayushman Arogya Mandir sub-health centers, which are non-delivery points, and 129 for the delivery points sub-centers. We have only one checklist for the Ayushman Arogya Mandir sub-health center. So this is when we are talking about the area of concern G. As you can see, there are total set of 10 standards, right from G1 to G10. But these 10 standards are applicable to only secondary care level of the facilities. At the CHC level of the facilities, that is the first referral units category of the CHCs, we have total 7 standards at CHC for under area of concern G. At PHC level, we have 4 standards under area of concern G. At the UPHC level, we have 3 standards only. And at the Ayushman Arogya Mandir sub-health centers, we have total 5 standards for when we are talking about the area of concern G, um, quality management. So what we will do today is I will give you an overview about the requirement of each standards, and subsequently in the next webinars we will be detailing you on each specific implementation point against the each standard. For example, I will brief you on today's the overall intent of this area of concern G, and in the subsequent sessions we will look how the facility will implement these standards and what are the responsibilities of the facility to meet the national quality assurance standards, and subsequently so that they can achieve the certification against these particularly standard requirements. So there are total 10 standards as I was talking about. The standards of G1 talks about formation of a quality team that will be responsible for the implementation of all the national requirements of national quality assurance standards at the facility level. G2 talks about monitoring and measurement of the patient and the employee satisfaction so that the low scoring attributes can be identified uh, and the services can be improved further. G3 talks about having an internal and external quality assurance program in the healthcare facility so that the quality of the services can be maintained. Standard G4 talks about having standard operating procedures for each type of the activities, right from the departmental level to other activities that are being implemented. So G4 talks about a documented standard operating procedure that has to be there to avoid any variation in the set of activities which is being carried out by each category of the staff. G5 talks about identification of the ideal process that has to be there in a healthcare facility to remove the non-value adding activities and to streamline the processes, and so that further improvement in the processes in the healthcare facility can be made. Standard G6 talks about the facility about mission, vision, quality policy and the quality objectives that has to be there in a healthcare facility so that the implementation can be made in line with the requirements of the mission, vision, quality policy and the objectives of the healthcare facility. Standard G7 talks about how the quality tools and the methods, right from process mapping, brainstorming, why analysis, root cause analysis, these can be implemented so that you can improve on the services, on the problems, and identify the ideal roadmap to improve the particularly processes in your healthcare facility. These 3 standards, that is G8, G9 and G10, these are applicable only to the secondary care level of the facilities. When we are talking about the secondary care level of the facilities, these are the subdivisional hospitals and the district level hospitals that are there across all the states and the union territories. So G8 is regarding the risk management framework. G9 talks about identification of the risk management processes so that the risk identification can be done in the healthcare facility to avoid any accident and the incidences. And G10 particularly talks about the clinical governance framework where we are covering the requirements of doing the audits, that is particularly related to prescription audit, the clinical audits, the death audits that has to be done to improve the clinical services that are being provided in the healthcare facilities. So coming to the overview of standard G1, standard G1 talks about having an established organization framework for the quality improvement. So when we are talking about the organizational framework, here what the expectation from the National Quality Assurance Standard is that there should be some one team in a healthcare facility that will look for the implementation, how these standards are being implemented in the healthcare facilities. So under G1.1, we are looking at a quality team and a designated person for coordination of all these activities. So this particular person can be the quality manager, a hospital administrator, or a designated person from the staff itself. If there is no separate post for the quality manager in the healthcare facility, then this particular person will be made designated for this particularly coordinating all the activities that is related to the quality implementation in the healthcare facilities. G 1.2 talks about that when the facility, there is a team that is in place in the healthcare facility, then what activities this team has to carry out so that the monitoring of the quality implementation can be taken up in the healthcare facility. So when we are talking about this particularly at the district level of the facilities, this is the suggested quality team at the district level or the subdivisional level of the facility. This particular team can be replicated for the FRU CHCs also. So here, your civil surgeon or the medical superintendent can be the invitee member to this particularly quality team. The medical superintendent of this healthcare facility or the subdivisional or the district level of the facility will be the chairperson. All the clinical departments head, right from your general medicine to HODs of the gynae to the ortho, whatever the departments that you have, that will also be the part of this particularly quality team, because the quality intervention has to be taken up at the departmental level. It is not the duty of the quality manager only to implement these processes, but processes has to be implemented at the departmental level, and the head of the department is well aware what is going on in its department, where the challenges are. So these are mandated to be included in this particularly team. Your hospital administrator will also be the part of this particularly team. Then the core functionalities of the hospital, that is the person who is responsible for the maintenance activities in the healthcare facility. Your biomedical engineer who is responsible for the equipment management in the healthcare facility. In charges of the store department, your medical record department will also be a core member of this quality team when we are talking about the establishing a quality team at the district level of the facility. And then obviously the hospital manager, the quality consultant will be the part as a member secretary of this particular team. Coming back to the Ayushman Arogya Mandir Sub-Health Center, here, because the staff is very less, the core component of the team will be the community health officer, the nursing midwife, the staff nurse that is posted in the Ayushman Arogya Mandir Sub-Health Center, your multi-purpose workers, and obviously ASHA. So these will be the core members of the team for responsible for supporting the facility for implementation of National Quality Assurance Standards. Here, the medical officer in charge of the mother PHC will be the invitee member of this particularly team, because it is the responsibility of the medical officer in charge of the PHC to review the activities of the sub-health centers. So, so he will also be included as an invitee member to this particularly quality team when we are talking about the Ayushman Arogya Mandir sub-health centers. So once you have framed this particularly teams in your healthcare facility, so what will be the particularly requirement of this particularly team to review the services that are being provided in this healthcare facility? So what the team will do, they will meet on the monthly basis and review all the activities that are related to the implementation of National Quality Assurance Standards in the healthcare facilities. So for this, a monthly review meeting will be conducted, and it is expected from this team that whenever such meeting is being conducted in a healthcare facility, the minutes of the meeting has to be recorded so that a follow-up action in the next subsequent meeting will be taken up. What were the discussions that were held in the previous meeting? Then what they will review? They will review the progress of the quality objectives and the targets that has been set by the healthcare facility. They will discuss on the gaps that are there in the healthcare facility. For the gap identification, your Kayakalp tool or National Quality Assurance Standard checklist will be used. So it is expected that the team will review what are the departmental level gaps in the healthcare facility, and they will discuss on the gaps, how the facility can work on the closure of these identified gaps. Then it is also expected that they will prepare a time-bound action plan so that performance of the healthcare facility. Here in the next session, we will be talking about the indicators in detail that is expected from the healthcare facility to be monitored. That is the requirement of the standard. So quality team will review the indicator also, and the any indicator which is not going as per the performance requirement of the healthcare facility. Again, this quality team will work on how those indicators can be improved so that the services can be improved in the healthcare facility. Again, the audits that has been done by the different audits that has been done in that particular month, those reports will also be discussed in this particularly monthly review meetings. And the core component of the patient satisfaction will also be reviewed in these particularly meetings, so that the low performing attributes can be identified in the healthcare facilities and the improvement can be made on those particularly points as well. So coming to standard G2, standard G2 talks about facility has an established system for patient and employee satisfaction. So as you all are aware that one of the definition of the quality is to meet the customer's expectation. So once, if we are not measuring the customer expectation, be it our internal customer, that is the employees, or be it our external customer, that are the patients and the beneficiaries that are coming to the healthcare facilities, we cannot improve on the services that are being rendered by the healthcare facility. So this standard is inclined towards monitoring the satisfaction level of both these internal and external customers, that is the patient and the employees. Standard G2.1 talks about patient satisfaction surveys are being conducted at the periodic level. So here, when we are talking about the periodic level, the periodicity is on the monthly basis. For the employee satisfaction, the periodicity can be on the 6-month basis or annually also. But for the patient satisfaction, a monthly survey has to be conducted for the patient satisfaction level in the particularly for that particularly healthcare facility. At G 2.2 talks about the analysis of the patient feedback and to do the root cause analysis for those particularly low scoring attributes that are coming up again and again, due to which the patients are dissatisfied with the healthcare facility. Usually, the three components, what we are seeing at the national level that are coming up again and again at the patient satisfaction level, is the cleanliness level in the healthcare facility, the behavior of the staff, and availability of the drugs. So these it can vary from healthcare facility level to various from facility to facility, but these are the three uh, lowest scoring attributes. So it is expected from the healthcare facility to improve, continuously look an eye on improving the cleanliness level in the particularly healthcare facility. Be very courteous when we are communicating with the patients and the beneficiaries, so that the behavior can be interpreted by the patients in a compassionate manner. And also look at the timely availability of the drugs, that is timely intent, a strong inventory management system, both at the departmental level at your pharmacy level, so that availability of the drugs can be improved, um, and a supply chain can be maintained, considering the lead time, whatever you have for that particularly facility to get the drugs that are needed to be available in the healthcare facility. So G 2.3 talks about the preparation of an action plan to address these low satisfaction in the healthcare facility. So coming back to the patient satisfaction survey, as you all know, patient satisfaction survey is an integral part of the quality improvement activities that has to be undertaken under the National Quality Assurance Standard certification requirement. Here, for a facility to get state certification, minimum 65% of the beneficiaries are needed to be satisfied with the facilities that are being provided. And similarly, when the facility is going for the national level of the certification, there should be evidence that 70% of the patients and the beneficiaries that are coming to the healthcare facilities are satisfied with uh, the services that are being provided by the healthcare facility. So it is a core component not only for monitoring the service level, but also to meet the state certification criterias and the national level and cost certification criterias. So what it includes the analysis of a patient feedback, which will be captured through a structured format. In the subsequent sessions, we will be talking about the how these particularly, structured formats can be developed and can be used. What is expected from the district quality assurance teams, that there should be one single structured feedback form for each level of the healthcare facility, so that it is easy to analyze and it can be replicated for each level of the facility. So based on the patient feedbacks, a root cause identification of the low satisfaction level has to be carried out. A definite action plan has to be prepared for this particularly low scoring attributes, and facility should encourage the departments and should also motivate itself to take the corrective and the preventive action, so that these particularly low score, the dissatisfaction points doesn't come up again and again to the healthcare facility. So this is a kind of a format where how you can just do the service, and there is particularly how you can identify the low scoring attributes. As I said, in this particular sheet, you can see as per the analysis, there are two low scoring attributes, that is the attitude and communication of the doctors and availability of the prescribers. So when you have identified these low scoring areas or the low scoring attributes, there should be some mechanism which the quality team that has been formed at the healthcare facility, which will undertake to address these particularly low scoring attributes, prepare an action plan for them, and then address those low scoring attributes, so that the satisfaction level on those particularly low scoring attributes can be improved. So what actions need to be taken to improve those particularly low scoring attributes? These has to be discussed in the monthly quality team meetings. A definite action plan need to be prepared, and compliance to the action should be reviewed monthly. It should not be in such a way that you have prepared an action plan and then you are not looking at that particular thing, that it will be going with. It will be the responsibility of the quality team to review the action plan on the monthly basis also. G3 here talks about the facility has an established internal and external quality assurance program in the healthcare facility. So when we are talking about the internal and external quality assurance programs, here the expectation from the healthcare facility is that a departmental level internal quality assurance program will be conducted. So internal quality assurance program will be done based on your monthly inspections, the monthly audits that you are doing for this particularly against the departmental checklist of national quality assurance standard requirements, and daily round schedule, whatever the checklist or whatever the parameters that you have established in the healthcare facility. For example, let's take a simple example of having a housekeeping checklist. So that housekeeping checklist will serve as an internal quality assurance program for the cleanliness or the infection control practices in that particular department. So the requirement of the standard is that a departmental level internal quality assurance program is needed to be there. For that, you can use the KAICL, the National Quality Assurance Standards departmental checklist, to regularly review what are all the activities that are being undertaken in the departments, in the particular department. Then here we are looking at under G 3.2, the requirement that is that facility has established external quality assurance program at the relevant departments. So here, when we are talking about the external quality assurance program, here we are expecting that the teams for the from the nearby facilities or from the district quality assurance units or the state quality assurance committees are reviewing the performance of the departments based on the national quality assurance standard checklist only. And for the particularly, diagnostic departments, that is the laboratory, there should be some mechanism of having the external quality assurance program for the tests that are being carried out in that particularly laboratory of the district hospital or the SDH level of the healthcare facility. At G 3.3, we are looking at having an established system of the use of the particularly different departmental checklists, which will serve, as an objective assessment methodology so that the non-compliances can be identified against the standard requirement and department can work to close those non-compliances so that the national quality assurance certification can be achieved by the healthcare facility. G 3.4 talks about having a definite action plan to address the gaps that are being observed by doing the internal assessments of the healthcare facility, and then subsequently there should be some under G 3.5 planned actions are needed to be implemented through the use of the quality improvement cycles. Please don't worry about these particularly terminology that we are using like PDCA. PDCA is Plan, Do, Check, Act. During this particularly series of the webinars, we will be taking up each and every tool and we will be explaining in detail how these particularly tools will be implemented to improve the quality of the services and for the gap closure. So this is the component of your internal and external quality assurance program. If you have to meet the requirements of the National Quality Assurance Standard certification, here we are looking at the use of the internal and peer assessment using the National Quality Assurance Standard departmental checklist. What is expected that the non-compliances are enumerated, gaps are identified, gaps are classified both at the right from the departmental level to the state level. The prioritization of the gaps can be done and the follow-up closure for the gap that has been identified can be taken up by the healthcare facilities. So comparing the internal quality assurance program and the external quality assurance program, when we are specifically talking about the laboratory department, the internal quality assurance program will be conducted by the laboratory staff. It will be within the lab. It is a daily activity or a monthly activity or as per the, the load of the samples of that particularly laboratory where you are doing your internal quality controls test for each level, for each category of the test. And it is used for ensuring the day-to-day accuracy in the particularly all the diagnostics that has been taken up in the laboratory. When we are talking about the external quality assurance, program, here we are expecting that the laboratory is sending its samples to some external, quality certified external um, labs which will be undertaken at the periodicity of the monthly, quarterly or the yearly level, and it is more related to the proficiency testing of the functionality of the lab. Laboratory within the district or within the state, it is also acceptable under the national quality assurance standard requirements. But the only requirement is that wherever your lab samples are being sent, that lab has to be either national quality assurance standard certified IPHL labs or an NABL laboratory. So for conducting the assessment schedule, that is the part of your internal assessment, internal quality assurance program. This kind of a format can be prepared for the internal preparing an internal assessment schedule. For example, in the month of January, you want to, uh, conduct the internal assessment of the radiology department. So it has, or the any, your SNCU or the labor rooms. So here what you need to do, first of all, you need to priorly communicate to the department that your internal assessment will be carried out. Then who will be responsible for particularly conducting those assessments. And during the assessment, once it's priorly communicated to the department must tell that during those dates, who will be available to get those assessments done in the healthcare facility. So please mind this particularly, a thing. In the absence of it, the internal assessments or the internal assessment of the particular department should not be carried out in absence of the departmental in charge, because departmental in charge is responsible for the overall functionality of the department. So if he will be not be available on the day of the assessment, it will be very much difficult to identify the actual gaps in the healthcare facility, and there may be chance that the closure of those gaps will be difficult because departmental in charge will not be aware about those particularly identified gaps. So it is suggested that always the internal assessment should be carried out for the particular department in presence of the department in charge of that particular department. So coming to the gap analysis, sorry. The gap analysis is related to your structure, process, and the outcome. This is the particularly um, platform on which the National Quality Assurance Standard has been framed. So gap can be related to your infrastructure, human resource deficiency, or the deficiency in the availability of the drugs and the equipments. Gap can be related to the processes that are being implemented, which is related to the clinical care processes, your administrative process, and the overall functionalities. Then the gaps can be related to the outcome of the care, that is where you can through your indicator monitoring you can find where the work has to be done. So once you are running the checklist in the particular department, and there is any non-compliances, that is where you are getting any 0 or 1 score, that will be your gaps on which a department has to focus to meet the standard requirements. What is expected that you write down the gap statement, assign particularly person responsible that will address that particular gap in the department, assign the gap classification. The gap classification can be at the facility level, at the departmental level, at the facility level, or at the district level or at the state level, but it has been observed that usually 80% of the gaps can be closed at the departmental level or at the facility level only. Then assign a gap severity rating to that particular gap. When we are talking about the severity rating, it is severity can be that is related to the direct patient care or the safety of the staff. So any gap that is directly impacting the patient care and the safety of the staff or the beneficiaries that are coming to the healthcare facility will be considered as a severe gaps, and the facility must prioritize those gaps to address first for the gap closure. Standard G4 talks about having established and documented and maintaining standard operating procedures for all the key activities that are being undertaken at the departments. So G 4.1 talks about department standard operating procedures are available for each and every activity. G 4.2 talks about adequate resources as per the standard operating procedures are available for. G 4.3 talks about staff is needed to be trained on these particularly standard operating procedures, and during your assessment methodology, the during your assessments, the assessors are looking at this particularly component, what are the standard operating procedure at the departmental level, and whether the staff is doing the activities as per those SOPs, and whether they have been trained on those particularly SOPs. So these SOPs are not only for the, particularly to meet the standard requirement that document has to be there, but more so over the staff is needed to be trained on those particularly SOPs. Otherwise, there is no use of having those particularly SOPs in the facility level. Then subsequently, G 4.4 talks about that these documents should be approved and controlled. So when we are talking about approved, it should be approved by the departmental in charge. See, these are the activities that are being carried out, and what is the best way to do those activities in the department. So it has to be approved by the departmental in charge, and it has to be controlled, meaning there should be some identification of these SOPs, which document is applicable to which department. So that is the overall requirement of standard G4. When we are talking about the documentation to meet the national quality assurance standard requirements, this is the particularly hierarchy of the documents that is expected that the facility will be maintaining. One is your first will be your quality manual. So quality manual will give a brief description about the healthcare facilities. What are the all the scope? What is the scope of the services that are available in this facility? Who is what is the organogram? That is, who is the medical superintendent? What are the administrative structure and the clinical? What is the administrative structure and what is the clinical structure that has been established in the particularly for the administration of the clinical services and the administrative services at the district level of the hospital. So quality manual gives an overall intent how the NQA standards will be implemented right from the you know right from overall to maintain the hierarchy in the system, right from particularly governance mechanism to the departmental level. What is the particularly system to implement the quality? So that will be covered under the quality manual. There will be a set of quality policies and the quality objectives that the facility has to meet, a set of standard operating procedure which will cover in detail about the steps for doing those particularly activities that is related to particularly uh, one process in the department. Then there is a set of work instruction, how these activities will be carried out, and to meet all the requirements, some records and the formats that will be generated. So this is the overall hierarchy of the documents and the records when we are talking about having the quality management system in place, and as an evidence to show that the activities are being carried out as it has been documented as the part of your quality manual and the SOPs. So this is the examples of some examples for you. Quality policy, it is a definition. As a definition, the management's commitment to the quality, one of the particularly example that has been highlighted in this stuff, that quality policy can be that your hospital is committed to provide timely patient-centered or the safe patient care. Then the quality manual, as I said, gives you an overview of the hospital's management quality management system. It includes all the process flows, the responsibility of the staff, then a set of the standard operating procedures which will cover the activities of that particular department. So taking the example of the OPD, all your activities related to this registration, vital monitoring, consultation, prescription writing, how and when the pharmacy, dispensing of the medications will be taken up. So these are the these are the activities that are taking up in the OPDs. So it is expected that facility will be creating a standard operating procedure for each set of activities that is being carried out. Then work instruction gives you the detailed guidance for that particularly specific activities that is being highlighted as the part of your standard operating procedure. These work instructions, for example, in OPD can be the instruction for monitoring of the vital signs, and then the particular record and formats that are required to capture the evidence ki yes, that particularly process was followed. So, for example, coming back to OPD, your OPD form, the consultation notes in the patient file, your prescription slips, and the feedback form will be served as an evidence that these activities will be carried out. Standard G5 talks about that facility maps its key processes and seeks to make them more efficient by reducing the non-value adding activities and the wastage. Standard 5.1 measurable elements. There are three measurable elements under this particularly standard. 5.1 talks about facility maps its critical processes. 5.2 that non-value adding activities are identified, and 5.3 talks about that facility take the corrective action to improve the processes based on the process mapping that has been done by the healthcare facility. So coming to this, um, what is a process map? So process map is a graphical representation of the series of the steps of the processes. It is also a pictorial representation of the sequence of the actions that are needed to be carried out. And in general, it traces the flow, how the activity will be carried out in each department. So why it is required? It gives you a visually representation of the work processes that has been being carried out at the departmental level. It provides a common understanding of the entire process. um, एक बार आवाज check करिए. It gives you overall, it a common understanding of the entire process and the specific roles of all the persons who are responsible to carry out those set of activities. It can identify the problem areas, and it will serve as a great problem solving tool to improve the processes in the healthcare facility. So when we are talking about identification of the value and non-value adding steps, value adding steps are those steps that are directly impacting the patient care or the outcome. For example, again, coming to the OPD, the value adding activities will be the vital sign management, doctor consultation, prescription writing. For the non-value activities are those activities that are not directly helping the patients and should ideally be minimized or removed. For example, waiting time, unnecessary walking between the counters, long queues, inappropriate waiting areas. So these non-value-added activities has to be identified, and from the ideal process, it has to be removed so the time management can be taken up. To give you an example how the process mapping is done, this is the overall registration process. The overall OPD consultation process that is being depicted in a form of a chart. Here you can see as a first set of activity, patient arrives at the registration desk. So what is to be confirmed? Is there a line for registration? If yes, then patient waits till he is called. It is not that he is standing in a queue or is, so there should be some calling system. If there is no line, then patient goes to the new counter, then patient is registered. If doctor is available, doctor's availability has to be confirmed, and it is seen by the. So this is just an overall graphical representation how these processes can be graphically represented. So here you can identify share with you all the set of the ideal processes that has to be there at the departmental level. Standard G6 talks about having a defined mission, vision, values, quality policy, quality objectives, and a strategic plan to achieve them. So here 6.1 talks about a defined mission statements at the facility level. 6.2 talks about having the defined core values for the healthcare facilities. So these core values can be non-discrimination, transparency in the communication, your ethical guidelines, the competency, etc. Then what is expected that you have defined quality policy, which is in concurrence with the mission vision of the facility. Then having the quality objectives in place so that the measurements or the performance of the healthcare facility or the department can be taken up, whether the objectives that was set. For example, you wanted to reduce your patient satisfaction from, increase your patient satisfaction from 3 to 4. How these targets are being met or not. Then G6.5 again talks about having the mission policy and the vision policy. G6.6 talks about having a strategic plan to achieve those mission, quality policy, and the objectives. And then 6.7 talks about that the facility periodically reviews the progress of the strategic plan towards the mission, policy, and the objectives. This activity has to be carried out at least in a month, and it can be taken as a part of your monthly review meeting. So when we are talking about this vision, mission, values, objectives, and the strategic plan, visions is your long time aspiration where facility wants to see itself down the line, maybe in the 5 years down the line, where the facility wants to achieve. For example, vision statements can be that you want to achieve the National Quality Assurance Standard certification and want to sustain this particularly certification subsequently for the 5 years. So that will be your vision statement. The mission statement is the core purpose where the organization exists. One of the example that has been given and shared with you as a part of this slide is that your mission statement can be to deliver the comprehensive and equitable healthcare services with compassion and the professionalism. Values are those core component that we are expected from that is expected from the healthcare staff, which is responsible on the principles of the guiding behavior and the decision making. So it has to be, it can include patient-centered care, safety, hygiene, integrity, and the continuous learning approach by the healthcare staff. When we are talking about the quality objectives, these are the specific measurable targets to support the mission statement of the particularly healthcare facility. So one of the quality objectives can be to reduce the waiting time by 20% within the next 3 months and achieve a 95% satisfaction level within next 2 months and reduce the hospital acquired infection by 15% in this particularly year. So these objectives need to be smart, that is specific, measurable, attainable, reliable, and it should be time bound. It should not be like that you have set an objectives and you are not monitoring the progress of that objectives, and so that it can never be achieved. So be very clear what you want to achieve in next 2 months, what you want to achieve in next 3 months in a quarterly basis or on the biannual basis or on the annual basis. So this is the part of the set of the objectives. Then your strategic plan talks about the long-term plan to achieve these objectives. These strategic plan example can be that to implement the hospital management software by 2026, train the staff on the infection prevention by 2026. So this is the strategic plan, how you want to go about this particularly implementation of the standards in the healthcare facility. Coming to standard G7, G7 talks about continually improvement by practicing the quality methods and the tools. Under National Quality Assurance Standards, we have covered basic 7 tools are being covered that the facility can use to monitor these quality tools and the quality methods. These are the difference between the quality method and the quality tool when we are talking about. So this is for your reference if you want to say. When we are looking at the different methods, so one method can be the brainstorming. So brainstorming for any problem that is there that you have identified as a gap in the healthcare facility. So as a quality team, you have to work that why this particularly gap is there. So for that particularly exercise, brainstorming method can be used, which is a group activity. It helps to generate a large number of ideas, and it should be done at the departmental level when all the team members are there. So there are some basic steps for this rules when we are talking about the brainstorming. Um, you know, every idea should be encouraged because under quality, we consider that every idea can be a change making idea in the particularly gap closure. So every idea has to be heard. And then as a group, you have to identify which is the most, particularly relatable idea that is there that can resolve the gap that has been identified in the healthcare facility. Then other method we have YY analysis. It is also known as the root cause analysis. It helps the team to reach beyond the evident reason or the cause of the hazard. For example, there can be a case that there is the non-availability of the wheelchairs at the entrance or at the emergency department. So now the departmental in charge may find yes that the wheelchair was not present, but the root cause can be that because the spare parts were not available in the healthcare facility for that particularly wheelchair. So because maintenance was not carried out, so these underlying problems will never be evident when we are looking at the gap as a gap statement. So as a team, we are responsible to identify the actual reason or the cause of that particularly gap that is happening again in that particularly healthcare facility. Here, what is expected that we are not looking at why it is not there. You address each why at least 5 times so that we can go into the detail or the root cause of that particularly gap. Then the other tool that we can use, that is the Pareto's analysis. It is a 20-80 rules. Here, what is being said that 80% of the errors are due to only 20% of the causes, or you can say 80% of the benefit is through 20% of the actions that are being taken. So this is the Pareto analysis that can be taken up. It is it can be used to maximize the efficiencies of the processes and can be used to identify the major cause of the errors. Then there is a fishbone diagram. It is also known as the cause and effect diagram. For every problem, there can be 6 particularly relatable causes to that particularly gap or the problem statement in the healthcare facility. These 6 identified uh, causes can be related to the HR, can be related to the equipment, it can be related to the material, it can be related to the method of working, it can be related to the measurement, and it can be related to the overall environment. So these are the, how the arrangement. So this is overall how the arrangement can be done for the particularly uh, identifying the causes of those particularly problems. And then there is the run charts. Run charts give you an overall trend of the particularly indicators that are being monitored. Usually these run charts can be seen in the laboratory departments where we are maintaining the LJ charts for the internal quality control that we are being maintained. So this gives you an overall trend of the whatever the activities or the performance of that particularly department. So, and it can also identify the outlier. For example, if you see in this particularly slide, here you can see that your, particularly control was in line with the requirement, but suddenly some shift has taken up. So wherever this particularly shift has taken up, again, the quality team should focus that what has happened on that day and what was the underlying problem so that such outliers can be identified and the facility can work to close those particularly outlinement in the particularly tent. Then the method is 5S. It talks about the maintenance of the department. Here, what is expected that it is a 5-step method that has been used to maintain your working desk, your department. Here, 5S means sort, set, shine, standardize, and sustain. Under sort, we are looking at distinguishing between the necessary and the unnecessary things, getting rid of what does not is needed in the department or at your desk level. Then set in order, practice an orderly storage of the items that has to be there. And then shine, create, a clean workspace. removing all the non-value unnecessary activity and things in the departments, then standardize and then sustain this practice at the departmental level. Then histogram is the particularly this particularly set of charts that can be prepared, that so histogram can be used to depict the performance of that particularly department. Coming to PDCA is a plan, do, check, act technique. It is the core component of continuously it is a core component which is continuously working on improving the any activities that is being carried out at the departmental level or the facility level. As in generally quality, we say that quality is not a destination, it is a journey. So facility must thrive upon continuously improving on the performance and the activities at the departmental level, at the facility level. For that particular thing, PDCA is used, that is plan, do, check and act, is an a four problem solving model used for improving a process or carrying out the change. This is the overall process. So under plan, we identify and prioritize the opportunities. We develop an aim statement to for the closure of that particularly gap, describe the current process, collect the data and the current process, identify all the possible causes that are there for that particularly gap, and identify the potential improvement, how that gap can be closed. Based on that particularly potential improvement model, develop an action plan. Then your do part start, which is particularly related to the testing that particularly improvement plan. Collect and analyze the data, again document the problem and the observation and the lesson learned from the activities. Then again check whether the action plan that you have prepared for that problems that was identified, whether any improvements has been taken up on that particularly. Otherwise, again you go to the plan, again you do the current set of identify the current set of processes, again do the brainstorming techniques, and again develop an action plan, and then act on that particular thing. Here three set of actions can be taken up. One can be you can adopt, that is standardize and hold the gains. You can adapt, do and modify and try again, or you can abandon that particularly plan that you have prepared. But a cycle has to be taken up for each and every set of actions that you are taking up for the closure of that particularly gaps. Coming to standard G8, G9 and G10, these standards, I said, are only applicable to the secondary care level of the facilities, that is your district level of the hospitals and subdivisional level of the hospital. Here we are talking about risk management framework and plan and the clinical governance mechanism that has to be established. So coming to risk, risk is a possibility of something going bad or undesirable in the hospital. So what is expected from the healthcare facility, that there is a particularly a risk identification methodology is established in the um, healthcare facility. These risks can be classified into the four categories. It can be your clinical risk, wrong diagnosis, medication errors, HAIs. It can be related to the operational risk, that is the equipment failure, staff shortage, then even the financial risk of the budget overruns, delayed payments, and the environmental risk, that is concerned about the overall safety, when you are talking about the fire safety, unsafe infrastructure, etc. To give you more examples, it can be the pest, it can be the needle stick injury, how the medical gases had been, being handled. It can be related to the safe surgery practices. It can be related to the electrical fitting or the loose hanging wires. Risk can be related to the risk of patient fall and the slips. So standard talks about that there should be a risk management framework. G 8.2 talks about that the framework should identify and manage the risk at each level of the function. And G 8.3 talks about that there should be some mechanism of reporting those incidents and the risk to the departmental level. 8.4 talks about a comprehensive list of the current and the potential risk, including your operational, financial, and the risk is prepared at the departmental level, and the staff is again trained on those particularly risk management techniques, and the risk management is program is reviewed periodically. Standard G9 talks about um, Standard G9 talks about um, assessing, reporting, evaluating, and managing the risk as per the risk management plan. Here, G9.1 statement is that risk management plan has been prepared and approved by the designated authority, and there is a system of updation of the risk management plan at least in a year. This risk management plan should be communicated to all the staff and all the relevant stakeholders. Risk assessment criteria should be developed so that the severity of the risk can be calculated. And again, the periodic assessments of physical and the electric risk is to be undertaken at each and every departmental level. Similarly, these identified risks are treated based on the severity and the resources that are available, and a risk register is maintained, which is updated regularly. So this is the overall requirement under the G9. Under the subsequent sessions, we will talk in detail how the risk identification, how the risk severity metrics can be constituted at the departmental level, and how the facility will implement this standard G8, G9. Today, we are just giving you an overview of the, particularly requirements under the area of concern G, that is related to the quality management. So, as I said, example can be the patient fall, when you can assess the risk, evaluate the likelihood, its severity, risk rating, and then subsequently mitigate those risks by training of the healthcare staff, preparation of the standard operating procedures, doing the safety checks, and taking the preventive measure for all the identified risk, uh, particularly related to the identified risk that has been identified at the departmental level. So here, coming to standard G10, Standard G10 talks about having an established clinical governance framework to improve the quality and the safety of the clinical care processes. So under G10 is totally inclined towards the improving the services of the clinical care that is being provided in a healthcare facility. Here we are looking at the clinical governance framework. Under the clinical governance framework, there is one requirement of having an apex clinical committee. So this clinical apex committee will be responsible for evaluating all the clinical care processes. This evaluation will be carried out through your regular, clinical audits, the prescription audits, the medical and the death audits. So whatever the findings that are coming up on the clinical audits or the medical and the death audits, these findings are needed to be discussed in the apex committee, which is responsible as a part of the clinical governance framework, and the findings has to be effectively communicated to all the concerned clinical staff so that the clinical outcomes can be improved in the healthcare facility as well. So G10.1 talks about the a facility has a defined clinical governance framework. G10.2 talks about clinical governance framework has been effectively communicated to all the staff. 10.3 talks about clinical care effectiveness criteria is being set or not, and G10.5 is related to the conduction of the periodic clinical audits, including the prescription audits, the medical audits, and the death audits in the healthcare facility. So 10.5 talks about that whatever the finding of the these audits are, these are analyzed, and actions are being taken by the healthcare facility based on the audit findings. G10.6 talks about the governing body of the healthcare facility ensures accountability of the clinical care. So accountability will be there with the Apex Clinical Committee that will be framed. G10.7 talks about that facility uses standard treatment guidelines and implementation tools at the point of care. So this is the overall clinical governance. So it gives you an overall, umbrella vision of how all these elements to ensure the safe and effective care within the healthcare facility pertaining to the various area of concern and the measurable elements under the national quality assurance standards that has been set to improve the clinical services. The clinical governance framework gives you an overall umbrella of this particularly area. As I said, the components of the clinical governance is clinical effectiveness. The patient safety should be the core component of the clinic. When we are talking about the clinical effectiveness, conducting clinical audit, the part of risk management is also a core component. Then education and the training, staff management, and the information management. So information management is the conduct of the audits and generating of the audit findings and communicating it back to the responsible clinical persons. So when we are talking about the clinical effectiveness, here what is expected that care should be based on the best available evidences, clinical guidelines, standard treatment workflows as being given by the ICMR standard treatment guideline. It can be used at the state specific guidelines or any other clinical effective guidelines that are there. Then what will be the assessment of those particular things that the staff is aware about those particularly STGs, standard treatment guidelines, and the standard treatment workflows. Whenever the facility is conducted the clinical audit, it is conducting the audits against the whatever the processes that has been highlighted under the standard treatment guidelines. So that is your audit tool can be developed based on the standard treatment guideline for the particular set of disease. When we are talking about the patient safety, so patient safety, as I said, will be the core component of the measuring the clinical effectiveness. Here we are looking at the prevention of the harms and minimizing the error and the risk. As I said, clinical audits has to be conducted. Clinical audits will be conducted against the standard of treatment guidelines and the standard treatment workflows. And your staff need to be continuously trained to improve the you know um, clinical effectiveness at the departmental level. Some of the examples, so basic life support trainings, the ACLS trainings, your continuous medical education, training of your housekeeping staff on the housekeeping practices in the biomedical waste management. Even the simulation trainings can be carried out so that the clinical effectiveness of the staff can be improved. Then use of the management system in various states. There are various learning management modules that are available with the for with the states. The other management systems or the information system that can be used is the using the hospital management information systems, your electronic medical records that has been generated, the data that has been generated against each clinical decision. So these data can be used as your standard benchmarks to improve the quality of the clinical effectiveness that has been provided. So hey, this was an overview of the area of concern G, that is the quality management. What is the requirement of the national quality assurance standards? In the subsequent sessions that we will conduct this session on second and fourth Thursday of each month. And subsequently now we will be touching about on each standard, and we will guide you all how that standard has to be implemented in the healthcare facilities. Initial such sessions will be inclined on area of concern G and area of concern H, that is outcome. The link that is being given in this particular site, this link can be used to access all the training materials. These PPTs and the videos will be uploaded on this particular link, and you can use this particular link to get all the capacity building resources that we have at Quality and Patient Safety Division, NHSRC. Here again, I want to highlight two components. After the completion of these sessions, we will be sharing a post session, training questionnaire with you. All the participants who have joined, it is expected that you will be filling up this post training questionnaire, and there will also be a feedback link that will be shared with you. So please provide us the feedback so that we can improve particularly on this particularly scenario as well. So for the next session, I will be handing over this. So So for the next session today, we have with us Dr. Vinita Dhankar. Dr. Vinita Dhankar is consultant with Quality and Patient Safety Division. She is primarily responsible for hand-holding the states of Uttarakhand, Jammu Kashmir, Odisha, and for implementing the quality-related activities in these particular state. Dr. Vinita Dhankar will be taking you through the requirements of the area of concern H that talks about the outcome. So after this session, we will be taking up all the questions that were raised in the chat box, and we will also be sharing with you all the post training questionnaire set and the feedback link so that it can be we can get the appropriate response from you all so that we can improve for this particularly our webinar program. So over to you, Dr. Vinita, and a very welcome to this particular session.
Thank you so much, Abhay sir. A very good afternoon to all of you. I hope my slides are visible and I'm audible to each and every one of you.
Yes, you are audible, Vinita. Yes.
Okay, sir. Thank you so much. Okay, now we will be talking about the overview on the indicators. As we, in NQAS system, we talk about two types of indicators. That is your outcome indicators as well as your key performance indicators. So now in this session, we will be taking just an overview. So for further sessions, as told by Dr. Abhay sir, that during this webinar series, we will be going in more detail about area of concern G as well as area of concern H. Okay, now this session we will be talking about key terminologies we use in our system, that is different type of data sets, different type of information, knowledge. We talk about output, outcomes, and key performance indicators. We will also talk about the importance of indicators in different forms, and we will discuss what are the standards under my area of concern H, what are the measurable elements at different levels, and at the end we will be talking about the key points to remember when we are talking about the indicators in our system of NQAS. So now I start with the key terminologies. So in everyday of my working in my facility, we come across a lot of data sets. When a patient enters to a facility, starting from the registration every day till the patient exit in the form of discharge or the prescriptions, we fetch a lot of data from that patient. So do we actually calculate each of it? No, we don't. But do we need to calculate each of it? No, exactly not the entire data we need to calculate or take the information out, but whatever data is actually helping us to know what my facility is actually performing, that is important for us. In that matter, National Quality Assurance Standards have done the work in the form of area of concern H and key performance indicators, which help us to know how my facility is performing at department level. Also, overall, my facility is working towards the health indicators. So those indicators are defined in different formats and the formulas. So different kind of data, when we process that data, that is known as information. Raw data is of actually no use, but in our facilities every day we fetch a lot of raw data. Once we process that data and we come across with some information which is useful to us, that is with the help of different indicators. And when we actually use those indicators in form of some actionable points, with the help of some literature or our personal knowledge, when we know that this indicator is not performing well and we take some decision making, that is the actual useful part of that raw data we are collecting every day. So now talking about the Donabedian model, as you are already aware about, my national quality assurance system actually is built up on the Donabedian model. This model came in 1966. After that, a few other models also came into existence, like WHO model, Brumacco model, but still this model is the most dominant since then. Why? Because this model is actually the best so far, which helps us to know our facilities by dividing this into three. That is your structure part, your process part, and your outcome part. In this session, we are talking about the outcome part. Outcome is not a stand-alone entity, I would say. It depends on how your structure is and how your processes are behaving in your structure. That is the mirror of your outcome, is actually the mirror of your structure and process. Now we get confused many a time. What is the difference between these terminologies we use, the output, outcome, and key performance indicators? So output is what? It is basically the immediate result of your inputs. Whatever the input you are putting, the immediate result of that input becomes the output. Whereas outcome is what is the impact? The difference is the immediate result is your output, whereas the impact of that particular process on the system becomes the outcome. And your key performance indicator is what? It is the success of those. Basically, in simple way, if I talk about, it is the priority metric that tracks performance in the form of some overtime. So what was the performance last month? What was the performance today? And compare it with my national targets. So key performance indicators is basically help us to know whether we are in alignment with our targets or some kind of benchmarking or not, how my facility is actually performing, this is mostly helpful for your state level and national level to know how my health system is actually working. If I take an example to make you understand the difference between these three terminologies, so you can think that you are conducting a training for the ANC protocols. So now you are conducting a training for ANC protocols. The number of staff which have joined the training and the completion of training is your output. So suppose 50 of the staff has, or ASHA has joined the training. Now the 50 are trained. That is the simple output of your training part. Now what is the outcome? Now the effect of that training and your how many number of pregnant women who have completed minimum 4 ANCs becomes the outcome of that particular program, that this many of pregnant women have achieved, and now we are able to improve my overall impact on that training becomes my outcome. Whereas key performance is what? Now you have set some target, minimum, what is the coverage rate of that particular training, and when we compare it at the national level, that becomes your key performance indicators. Another example, suppose you are conducting a counseling session for anti-smoking. Now 50 adolescents have joined that session. So conducting the training and the 50% who have joined the session is the output of that training. Now out of those 50, how many have actually left smoking is become the outcome. That outcome or healthcare impact of that training is how much adolescents have actually left the smoking. Now overall impact is what? It is how the non-communicable diseases arising from that particular smoking, how they are actually affecting or helping my healthcare system for the improvement. That is your key performance indicators. Now, why do we need indicators? Now, coming to the importance, until unless we know how one system is important, we are unable to actually make the improvement. Now, if you can say here, I am talking about expectations. So, why do we need to know about expectations? So, until unless I know, because if I talk about the definition of quality, it starts with meeting or surpassing my customers' expectations. So, until unless I know what are the expectation, what is the level where do I need to reach, so that helps me. The indicators basically help me to know where I'm standing today, where do I want to reach, and how can I reach that. So how part becomes your process, that how will you reach to your target or benchmark, but where you are standing in form of quantifiable numbers and where do you want to reach is with the help of the indicators. So here if you can see, I'm talking about expectations of patients. So patients in coming to my facility, or when we as a patient go to any facility, we definitely have some kind of expectations from the system. So from when I'm going to a public health facility, our general is the doctor should be available. Doctor, whatever doctor is writing the medicines, I should get those medicines on time. If a doctor is writing some diagnostics, that should be available. The doctor should talk to me with respect, and I should not wait the waiting time, and there should not be any error in my treatment. So these are the general expectations one has. Now we are also talking about not only the expectations of the patient. When we are talking about the indicators, we are talking about the expectations of service provider. As a service provider, when you're providing any service, you also have expectations from the system. You also have the expectations of the treatment you are giving, because you want, I should get minimum diagnostics and the resources so that I can provide better service to the patients coming to my facility. So I am expecting that there should be low mortality, morbidity in my facility, in my treatment. I am also expecting as a service provider that my improvement in my health indicators, when I'm presenting it in front of someone, there should be improvement from my last month or last, when I calculated the indicator, there should be some improvement. Enhanced productivity means I should be, my processes should be streamlined, that when I am completing any process, it should be effective and efficient. My processes should be effective and efficient. I should be able to do the same task in a resource, because I have limited resources and limited time. With the amount of footfall coming every day to our public health facilities, in our limited resources, we need to be productive as well as efficient in my services. So service providers also have many other, these are just a few. I know there are many other expectations, so we are also checking that. Now at the end, I'm talking about the healthcare system expectations. Now, as I told you in the KPIs, key performance indicators, they are with the help of these healthcare. These are what? These are the healthcare systems expectations. System is expecting, because in our country we are limited resources, so the system is expecting us that there should not be any wastage of any resources. So it should be optimal use of all the resources. Your system should be measurable, deliverable of all the programs, national health programs, improvement in my overall health indicators of the country, and your enhanced productivity in terms of volume. So these are the expectations of my system. So as I'm talking about, now we are discussing the importance of indicators. So these are the importance of indicators, that when we are able to reach or to some level, that we are able to complete the expectations of the people who are coming to our facility, we are able to complete the expectations of people who are working in the facility, as well as the overall country, as we are talking about public health system, how the government and how we are helping the overall healthcare system of our country. So indicators are the mirror of all of these things. So they are the very essential tool in our system, which help us to monitor our performance. But until unless we are able to calculate, we are able to see where we are standing, we cannot make the improvement. So indicators help us to know where what are we want to achieve, what is our current progress, where do we want to reach. It help us in guiding the decisions. How becomes the indicator help us in guiding our decisions. As I told you, if I take a simple example, they will simply help me if I talk about any infection rate, or how my healthcare associated infection rate, your surgical site infection rate. So it is simply help me to know what is my indicator rate right now in this month, and how do I need to take it further, or to reduce it if it is required. So it helped me to take my decisions more effectively. It helped me to evaluate the outcomes, how my particular department as well as my facility is performing, where are the major gaps, where do we need to work upon. So indicators are the major tools to know what are we doing. So now again, this is the same thing, importance where I'm talking about. It gives us, first we know where we are standing right now, if there is any gaps, if there is any increased indicator, and so that will help me to know, take my it becomes my critical information. So if somebody is asking you what is the result, so result is your indicators. So indicators help me to know what is the result. So for example, your subject, if in your exams you always see which is the subject where I have received the lowest marks, so that is your result. So indicators in the similar way help us to know where do we need to work upon in my next month. Performance monitoring, it helps us to take the decisions. Indicators help highlight the gaps in my service delivery. It helped me to identify the areas which require improvement, and it also ensure adherence to quality standards. It always helped me, whether if, as in the last session we talked about area of concern G, where Dr. Abhay told you about different tools and methods. So you are applying the tools and method, but you don't know whether you are improving or you are not improving. Indicators are the tools which will tell you whether you have applied the PDCA cycle or any control chart, run chart, any method or tool, whether it is giving me the right result or wrong result, whether should I be continuing with that particular cycle, or should I be dropping that cycle and trying another cycle. So all of that is from the indicators. So that is why indicators becomes a very important tool among all the processes we are talking about. It helped me to take all the decision making. For example, if you can see, guiding, planning, resource allocation, and strategic intervention. So how come it becomes our guiding planning also? Because we know which is the most important indicator where we need to work upon at first. Without that becomes your critical indicator. With this, without this indicator, we cannot miss this indicator. We cannot delay this indicator for further, so that we can work upon it the next time. No. So these indicators also help us to know what is the risk factor aligned with this particular indicator. If it is showing me any value which is against the actual acceptable value, we need to work upon it immediately. So these indicators becomes the guidance of becomes the light of guidance for us, that we need to take the urgent action so that we can improve and we can avoid any harm or any severe event. Entering into the now we will be talking about exact area of concern H, different standards, and your measurable elements. So if you see, indicators and area of concern H is always taken as it is because it's just the document part. But now I would like to clarify here that in your area of concern A to G, we are talking about different processes. We are talking about the availability. We are talking about the infrastructure. In E, we are talking about the clinical processes. In F, we are talking about infection control. So now H is what? H is, I told you, it is the actually shows you whether your structure is it in place, whether your processes are efficient and are in the proper, as in the last session you discussed about the process mapping. Also you're being told about the value added wasting of any step or value added processes. all of this help us to know, indicators actually help us to know whether my processes, whatever we are talking about from area of concern A to G, whether they are streamlined or not, whether they are in the right place or not. Indicators tell us which section requires action, which section requires further deliberation, where, so that we can improve that particular process. So indicators are the actual tool which gives you the mirror of your process and the work profile, what you are doing in your facility, starting from the registration of the patient till it is exit. All the tangible as well as intangible processes are being guided by the indicators. So it also helped me to know what is the improvement cycle I need to work upon. For example, adherence to infection control practices directly led to reduce hospital acquired infections. Now, if your process in F is not efficient, your indicator in standard H3 will always be high, and it will show you that, okay, this indicator is high. It means you need to work upon area of concern F, this section, so that you can improve the H part of that your area of National Quality Assurance Standard area of concern H. Now, and we have talked about output, outcome, and key performance indicator. But what is the major difference between among these outcome indicator as well as the key performance indicator in my NQAS system? In my NQAS system, whenever we are using the term outcome indicator, it means that your area of concern H in each departmental checklist. So whatever the departmental checklist you are checking from DH till subcenter, at DH level we have total 21 checklists. So each and every checklist have area of concern H at the last. So these are known as your outcome indicator. It is always and always department specific, but we are talking in our NQAS system. Whereas your key performance indicators are facility specific. These are the listing given in your operational guidelines. If I clarify here again, it is on page number 67 to 80. Why I am clarifying it? Because we have been observing this, that whenever a facility is being asked to show the outcome indicators, they show the KPIs, and wherever the facility being asked to show the key performance indicators, they get confused and they show the outcome indicators. So that is why I am clarifying here it again. Your outcome indicators are available in your checklist of particular department. It is department specific. So it tells how the department is actually working, how the department is actually working. Quantity and quality both are of that particular department are being checked through the outcome indicator. For the person who is sitting at a district hospital level, a manager, if they want to know which department is how the performance of that particular department, they can always get back to that department and check what are the indicators, how the indicators are actually behaving, what is the trend line. They can do the analysis of those indicators, how the indicators are doing since last 1 year, in each month, how the indicators are behaving. Whereas at the state level and district level, when your DQAU and DQAC and your SQAC wants to know how your indicators are actually moving toward for that particular facility or the facilities of that particular district, they always get back to these key performance indicators, because these are the mirror of how the health indicators are behaving in that particular state. So if they think that this district, this facility, this indicator is coming high or low, which is against the value, then they can always get back to that, what is the issue there and how we can resolve that particular issue. So key performance indicators are the facility specific, which are given in the operational guidelines from page number 67 till page number 80 respectively. Respectively means for 67 it is DH, then it is followed to your CHC, then PHC and UPHC. Now I again want to clarify one more thing here about the ARM subcenter. So people get confused with some 12 indicators in the form of KPIs are circulating in the states. So I want to clarify that there in your SSS guidebook of your ARM subcenter, there are total 28 indicators in area of concern H. For sub-center level, we are not asking you to give us another set of KPIs. For ARM sub-center, your outcome indicators are only the key performance indicators. There is not a separate set of KPIs for your ARM sub-center. So it is same 28 KPIs or your outcome indicators given in the assessor's guidebook of your ARM sub-center are your key performance indicators. So when you are submitting, when you're applying for the, specifically when we check your documents during your DVRs, it has been observed that many of the states or facilities are submitting set of 12 KPIs, then which is not right. You need to submit the complete set of 28 KPIs or outcome indicators, which is your area of concern H given in the assessor's guidebook of Ayushman Arogya Mandir sub-centers. Now, the another question arises many times is what is the minimum sample size when you are applying for the when you are applying for the national level assessment, national level NQAS certification. The minimum sample which we are asking you to submit is 30 for each month, not 30 not for 3 months. We are asking this data for the last 3 months. Few facilities, so you need to submit the data of 30 facilities for each month for last 3 months. So 30 facilities data you do not need to send, minimum is 30, but if you think that this does not applicable to your facility, you have a higher footfall, then we have also given the ideal sample size, which is given on the page number 116 of the operational guidelines for improving quality in public healthcare facilities guideline 2021. On page number 116, we have given this table, which you can see on your screen, where you can see if as per the footfall of your particular facility, you can see what is the ideal sample size you can check or you can take, so that you get the actual picture of your facility. So if you want to do so, that is also given, but if you think 30 you want to submit, that is also acceptable to us. Okay, now coming on the indicators. Now we have total 4 standards under my, or 4 set of indicators under my area of concern H. This is same for your KPIs as well as your outcome indicators. We are not differing to the terminologies for any of it. And in my KPIs also, we have divided it into 4 type of indicators, as well as for my outcome indicators, we have divided it into 4 standards with the same terminology. What is this? Standard H1 talks about productivity indicators, H2 talks about the efficiency indicators, H3 talks about your clinical care and safety indicators, and H4 talks about your service quality indicators. So it is same for each level. For sub-center till my district hospital, standard H1, 2, 3, 4 is same. And we have these 4 standards. As well as for my key performance indicators, we have classified or divided all the indicators in under 4 headings only, which is your productivity indicator, efficiency indicator, clinical care and safety indicator, and your service quality indicator. Now, what is productivity indicator? So when you are doing any service, so what is the volume of service you are providing, volume and frequency of services you are providing? All those indicators which are capturing about the volume of services are covered under my productivity indicator set, that is your area of concern H1. It actually helps us to know what is the utilization of services at my particular facility. Efficiency indicators, because as I told you in the beginning, in my system, we know there are the limitations of the resources against the number of footfall we are receiving every day. So how efficiently we are able to provide the services in my limited resources, what is the volume of services against my limited resources, is being covered under the efficiency indicators. All those indicators where we are calculating the volume of services against the limited resources, how efficient my services are, how efficiently my facility is able to utilize the resources and providing the Services is covered under my efficiency indicators. Third comes, now we are giving the services efficiently, but are they effective? Are they even safe for the people who are coming? Or are we only focusing to save my resources? So that is being covered under the clinical care and safety indicators, where we are checking how effective and safe my services are. Whether the services we are providing to my patients coming to the facility, are they actually effective or safe or not? That is being covered under my area of concern, H standard H3. So all those indicators are covered under here. Then comes your H, that is service quality indicators. As I told you in the beginning, that we talked about the expectations, whether my facility person who are coming to the facilities, what are their experience? Are they satisfied with the services we are providing? Only, not only about the clinical services, but how the staff, how they are behaving, how my services are, whether they are drinking water, cleanliness, hygiene, all of that we are checking through my last service quality of the services we are providing. So that, like, the indicators like your patient satisfaction score, your LAMA rate, etc., are being covered under my last area of concern, H standard H4 service quality indicators. So how these are divided at different levels? As I told you, at each level, these 4 standards are the same, H1, 2, 3, and 4. Same terminologies, same standard number, except at UPHC, where we have covered it under single standard H1, which includes all 4 as a measurable element. There is no difference in the indicators. These are still the same: productivity indicator, efficiency, clinical care, and my service quality indicators, but it is covered under single H1, and the second standard H2 talks about the benchmarking. Other than that, at all levels, standards are the same. It is divided into 4 standards, 1, 2, 3, and 4. Now, this is the number of indicators we have. At DH level, we have total 28 key performance indicator. At CHC, we have 24 indicators. PHC, we have 20 indicators, and UPHC, we have 15 indicators. At ARM Subcenter, as I told you, there is no difference between outcome and KPI indicator. They are the same. They are 27 for type A center and 28 for type B center. So outcome indicators for DH is 350, CHC we have 193, PHC we have 70, and UPHC we have 89. So this is the departmental. The number is high because outcome indicators are the department specific indicators. Key performance indicators are your facility specific indicators. Now we will talk about each of it as an overview only. Now, productivity indicators, as I told you, what is the productivity? It's tell about the volume of services we are providing. So what is the how it helped me? It helped me to plan my resource allocation. It helped me to know the monitoring the facility performance and identify any service gap we have. So productivity indicators help me to for the better resource allocation. These are the examples. These are just the examples I have taken from different levels, like OPD per month, bed occupancy rate, your C-section rate, blood transfusion rate, etc. So there are different sets at different level. It differs from one level to other level, but it can also be same as per the level of the facility we are talking about. So if you can see the table at the down part, number of KPIs at each level, that is your district hospital, CHC, PHC, these are the KPIs. You can see and you can observe the difference between DH and ARM Subcenter. At DH level, we have 7 KPIs under my productivity indicators. At CHC, we have total 8 indicators. At PHC, we have 6 indicators under productivity indicators, and UPHC have 5 productivity indicators, and ARM Subcenter, we have total 8 productivity indicators. Now, let's just understand with a simple example. If I talk about this indicator is your bed occupancy rate. So indicator of this is significance of this indicator, that it tells me about the utilization of my IPD or indoor services in my facility. So what is the formula? If you can see, the patient bed days divided by your functional beds into days in the month into 100. So now I just want to clarify here one thing, functional beds. So if suppose this is a question I have come across many times, that what are the functional beds? Suppose in your facility, that's at district hospital, you have sanctioned beds are 300, whereas the functional beds are 350. This is worst case. Now suppose you have in that case, which bed needs to be taken when you are calculating it? So you need to take the functional beds, that is your 350. Even if the sanctioned beds are 300, but if your functional beds are 350, when you are calculating this indicator, you need to take the functional beds. Similarly, if your facility have sanctioned beds 300, but you are working in a capacity of 250 beds which are functional, you need to calculate this indicator with the help of functional beds, that is your 250. So this needs to, you need to take care of. Then comes the numerator, patient census of each day added for the month, exclusion and inclusions. So I am not here telling you the different formulas and how to calculate it. I am just giving two examples only, telling you what are the important things when you are calculating it, and when an assessor is coming to your facility, what will be the questions they might be asking you. So these are few things. First thing is exclusion and inclusion criteria, which is very important. So they might be asking you different criteria, exclusion, and they might not be asking you what is the formula, but they might be asking you, did you include these, did you exclude these? So that needs to be known to your staff. If you think your staff is unable to remember, you can put you can put it on a paper and you can just tuck it over the wall where they are calculating it, so that they know which needs to be excluded and which needs to be included in particular formula of that particular department. So if for example, in this case, bed occupancy rate exclusion criteria is newborns in the maternity wards and your daycare patients. In denominator is product of functional beds in hospital and days in the month. Exclusion is again the labor room tables and the observation beds. Source of data is your daily midnight census. Okay, so for example, now this is the question, what would be the bed occupancy rate if total bed days, sum of midnight census is 7210 for a 300 bedded district hospital for the month of September 2025. So your total beds are 7210 divided by your 300 bedded. The functional beds in the hospital are 300. We are talking about, we are calculating for the September month. So the 30 days into 100, your calculation would come up as 80.11. It is a simple calculation. When you are coming across with some inclusion and exclusion criteria, you need to do the same, that we will discuss in the next example. Now coming on to the efficiency indicators. Now in the productivity, we are just checking the volume of services the facility is providing. In efficiency, we are checking how efficient my services in my limited resources. So achieve more with existing resources through process stand. How can you achieve it? By your process standardization, waste reduction, and your strategic resource deployment. So this is how you can increase the efficiency of services in your facility. So these are again few examples of indicators which have been included under my efficiency indicators. It is percentage of stock out as per EML, your dropout rate for pentavalent, dropout rate for NCDs, etc. Now these are at the down, there's a table given which is telling about the different key performance indicators at each level. At DH we have total 6 key performance indicators. At CHC we have total 5 key performance efficiency indicators. PHC we have 4 efficiency indicators. UPSC we have 3, and ARM subcenter we have 7. So you are observing that there is different. The ARM subcenter is majorly the highest number of indicators. As I told you, outcome and KPI indicators are for ARM subcenter, and at primary level we are majorly asking about the numbers. The percentage and rate are very less, hardly 1 or 2. Otherwise we are just asking about the numbers. For example, number of anemia cases treated successfully, etc. And even if we are asking about the percentages, they are the simple one, like percentage of cancer cases underwent treatment, etc. Now the next example, indicator of referral out rate. indicator of efficiency of clinical services. The formula is number of cases referred out from the hospital divided by total number of cases admitted in the hospital multiplied by 100. In this case, numerator is number of referred out cases each day added for the month. Exclusion is your LAMA and your absconding cases. Denominator is total number of patients admitted in the hospital for the month. Exclusion is your daycare cases. It is again the source of data is your indoor registers as well as your referral register. These formulas are also given on our website, which I'll be showing and discussing at the end. So this is just to make you understand. Coming on to the clinical care and safety indicator, here now we are checking the main thing, that is the clinical services. How my services are effective and safe to my patients coming to the facility. So we are checking this through my clinical care and safety indicators. Any indicator which is going beyond the accepted limit of for clinical care, we need to know that which process we need to improve in my area of concern directly. So clinical care and safety indicators are the direct reflection of my processes of the hospital, specifically the clinical processes, how my processes are behaving. So clinical monitoring, the objective is to monitor the clinical quality and patient safety outcome to ensure evidence-based clinical care delivery and continuous improvement. These are the examples of few of the clinical indicators from different levels being jotted out here. Percentage of AEFI cases reported, percentage of DOT cases reported successfully, number of children with diarrhea treated with ORS and zinc. As you can see, number here we are asking. This is for the primary care level, and your IUCD complication rate, percentage of high risk pregnancies, etc. from the secondary level. So at the end also, again, we have total 10 clinical care and safety indicators, KPIs. At DH level, at CHC level and PSC level, we have total 7 clinical care and safety indicators, KPIs. At UPSC, we have 4, and at ARM Subcenter, we have 10 clinical care and safety indicators. Another example is like average length of stay. This tells average length of stay tells us about the clinical care and safety, how safe and effective my services are. So it is the significance is that it tells me about the quality of clinical care and infection control. Formula is patient bed days divided by total number of discharges. Now you can see in the numerator what is my exclusion criteria. We will exclude the daycare patients in this. And in the denominator, which is your total number of discharges, the inclusion is your LAMA rate, death, referral, abscond cases, and your source of data is your indoor register. Now, can you see the exclusion as well as the inclusion criteria? What is the inclusion? LAMA, death, referral, and abscond, and your daycare patients in your numerator are the exclusion. Now, this case, for the SDH with patient bed days of 5,000, total discharges are 1450, deaths are 15, referrals are 55, absconding cases are 35, LAMA are 45, daycare patients are 10. What would be the your average length of stay? So what would be your here exclusion? As I told you, in the numerator, exclusion was your daycare patients, and in your denominator, rest all are your inclusions that you need to add when you are calculating the average length of stay. So when you calculate this thing, you will get that it is 3.12 days. So my purpose of telling you this is when you are calculating any formula, you need to take care about the inclusion as well as the exclusion criteria. Coming on to the last indicator, which is your service quality indicator, which is actually telling me how my services are acceptable to the patients coming to my facility or not, whether they are in line with the quality we want to achieve or not, will be calculated through my service quality indicators. These are the examples like LAMA rate, your PSS for the OPD, PSS for the IPD. These are the KPIs at different level. At key performance indicator is DH level, we have total 5 key performance indicators. At CHC we have 4, whereas at PHC, UPHC and ARM Subcenter we have total 3 indicators under my service quality and your service quality indicator for the KPIs. Now, outcome indicator measurement to improvement. So now you are, yes. So now you are calculating, you have measured it, you know the formula, the staff knows the formula, you have accepted, you have done the right calculation by exclusion and inclusion. What is the next step after calculating my indicator is the next important thing. Now you have calculated, you know where the facility is standing, you know how your department is actually working. What would be the next step? Next step comes the improvement. So indicators are the next step to my indicator is the improvement. So data collection, here first you have collected the data, gather information from this is. Now another important point I want to highlight here is when an assessor is coming at subcenter, for example at subcenter level, we have from the national level we have given the list of 7 registers which are required to be kept in a keep in a hard copy. Other than that, all the data which is present in the digital format in any of the software you are uploading it, you can definitely show to your assessor, and that is acceptable while doing the national assessment as well as the state assessment. You do not need to keep a copy of all the registers you are using while doing any process in the form of indicator or anything. You can definitely show your assessor that this indicator, this data is here, and that is acceptable to the assessors. You can always tell that this is being guided from the national level, and you can share the letter which have been circulated to the state that this is the minimum level of registers required at the subcenter. So the main point here is you do not need to do the rework of writing everything in the hard copies. It is acceptable to keep the your digital formats, your digital softwares working, and you can show that to your assessors. Second thing is action planning and remeasurement. You can always check that whether your indicator calculation, we have already talked about how you will going to calculate you need the formula, the methodology you need to follow. Then after that you will do the indicator analysis. You will check how your indicators are behaving, their trend analysis, their benchmarkings. You can create your own benchmarks, like how the facility indicators for the last month, for last 2 months, how they are behaving this month, what is the increase and decrease. Now if there is any change from the acceptable limit, you can see what is the difference in the process, what happened in this particular month that this indicator is increased so much. So you know that this indicator requires a certain attention, and you need to work upon the gaps which have become evident when you can see the indicator. After that you can do the action planning and remeasurement, and you can find, after that you can do the root cause analysis, what is the reason, as I told you, and the last you can do the action planning and remeasurement. So indicators if I say it is the last area of concern, but actually it is the starting point for your action planning, because it tells you where you are standing, where you are, where are the lacunas, where are the gaps in the system, and now you need to improve the processes from A to F. So being the last but being the first step for the improvement, indicators are the guiding light. These are just to show you that these are as I told you, that outcome indicators are available in your department specific guidebooks. So it is just to clarify that what I was talking about, outcome indicators. So what to look for, whether the facility has measured KPI for the current month. So this is for when the assessor is coming to your facility, they might be asking you about the current month key performance indicators, because when you are uploading any applications on the portal, you are giving last 3 months key performance indicators, but they can always ask last 3 months and the assessment, the difference between the when you are submitting the application and when the assessor is coming to a facility, the gap of 1 to 2 months can be there. So it means you can the assessor can definitely ask you about the key performance indicators. The other thing they can ask is whether you are submitting it every month to your district level and your state team. So when the assessor is coming for the assessment, they can ask the district team and the state team for these indicators. So they also need to keep the copy of these indicators. Whether baseline data for KPIs are available. When an assessor coming to your facility, then they always check, and they need to compare their improvement. So they will be able to compare the improvement from the baseline data. Baseline data could be two forms. Baseline could be the first time you have done the assessment, the calculate the indicators. Also, the baseline could be if you think from this the last month when we have calculated it, and then it was there was some mistake in something this month of, or for example, if I say in October month you have done the last assessment and you find that we are able to we can make that the baseline and we can do our improvements further, and we will check the trend analysis further from November, December, January. Then you can keep that as a baseline data. If you think in October there was some mistake and we did not calculate it right, we would like to take the November data as a baseline, that you can also keep. That is on the facility that they want to make their own baseline for the improvement in further months. Then, so the as you also, when you are implementing the quality system, when you are implementing, you need to check whether there is any improvement. As I told you, you need to compare the your trends from the last month to the current month, and in future months you can always check how your indicators are behaving, because it can happen that there are very slight difference in 1 month or 2 months, but when you will check for the entire year, you actually get to know how the system is actually moving towards with time, and you know which system where you need to take the action, so that in the next year you need to make the difference, or you need to improve that particular indicator. You can always check whether they have achieved targets of each KPI. So targets, if I talk about at my Laksha and Muskan, we have given the benchmarkings, not for my national quality and QAS. The benchmarking is not given. You can create your own target. If you think we want to reach to this place, you can make your own objectives, and you can always check whether you are able to achieve the objectives. Now, when an assessor is coming to your facility, they always check whether your indicators are in link with your objectives, or your objectives are in link with your indicators or not. If I'm talking about the department specific indicators, objectives, then the assessor, you can always show them, okay, this was the indicators which was not performing well, so accordingly we have created our objective in the last month, and this you can see the corrective and preventive action. This is the cycle we have done to improve that indicator, and this is the corrective and preventive action we have done, and now you can see for this month this is my result for this particular indicator. So this is the entire process. In your area of concern H, you are checking the indicator, you are getting some indicator, good or bad, that's fine. Once you get to know, you do the analysis of that indicator with time. When you get to know this indicator requires an attention, you include it in your objectives. After including the objective, you add it to your quality area of concern G, quality management system. You apply the methods and tools, you do the gap analysis, you find out the root cause, and after finding out the root cause, you actually make the improvement, and that becomes your corrective and preventive action. After doing the corrective preventive action, in the next month you show the improvement, and you can again calculate your indicator, and you can do the cycle. Now in this case, if you see, I have included area of concern H, we have included area of concern G. Also, what is the process you are improving on includes the area of concern E or F, whatever the process indicator we are improving. So this is how different area of concerns are actually interlinked with each other, and outcome indicators tells us which process requires attention. So interpretation validate of the data. After your assessment, you are doing the internal assessment in your facility. You need to interpret it, and you validate different form of data with the processes as well as with the action plan and corrective action. They should be in linked. It should not be like that your indicator is A, but you are improving the cycle about area of concern G. You are making your objective to something else, and your improvement is something else. So these things should be interlinked to each other. So you need to keep this in your mind. The last is the key points to remember. As I told you, for area of concern H, the major method of assessment is record review. It could be digital as well as hard copy. You do not need to keep both. You can show the digital one also, and you can show the hard copy, whatever is available at your facility. The compliance in your area of concern H could be full compliance or non-compliance. There is no partial compliance. There can't be that adha part, the half part of your indicator is fine, so we will give the 1 mark. No, when you're doing the assessment at internal level as well, or your district or state level also, there is only 0 and 2 marking. There is no partial marking in my area of concern H. Then the third is always look at what indicator set you are showing to the assessor. What assessor is asking, if they're asking you about the key performance indicators, be sure that you are sharing the key performance indicators. Also, when you are applying for the national assessments, you see what we are asking, whether we are asking for the outcome indicators or key performance indicators. Please upload the same thing which is being asked. The minimum sample size is 30 and your last 3 months data is required. Last 3 months kappa is also required separately, not as a one thing. It is not October or November and December combinedly you do the one thing and you upload it as a whole and one kappa. It is expected depending on the indicator also. If you think the indicator requires at least 3 months of the cycle to be run, that you can share. If you think the indicator requires the complete 1 month and then analysis and then 1 month again analysis, that can be done for each month. The last is source of data, relevancy of the indicator, and inclusion exclusion criteria should be known. As I told you in the beginning, you do not need to learn on your fingers about the formula, but you should be knowing what is the inclusion and exclusion criteria, what is the source of data, what I need to show when the assessor is asking for bed occupancy rate, which register or which data from which software I need to show this. That should be known to your staff. Now, this is as I told you, Quality and Patient Safety Division has created an automated sheet for the key performance indicators, which is available at our website for National Quality Assurance Standard NHSRC. I'll just take you through this website so that you understand. So you do not need to calculate everything in this website. If you go to or otherwise you can simply type on your Google that NHSRC. When you go to the official website in practice area, you can reach out to the Quality and Patient Safety Division. Okay. So this is the website for Quality and Patient Safety Division. It is the entire microsite. You can see here all the guidelines, what we are talking, all the directives, all the letters, everything is available on the website. Now I'm talking about the indicators. So if you can go to this section of quality scores and key performance indicators, click on to this and just scroll down to the end of this page, you will find out outcome indicators. When you scroll down it further, so the indicators are given for each level here, and for key performance indicators we have given it for DH, CHC, PH and UPHC. As I told you, sub-center we do not have separate KPIs, it is the outcome indicators only. So if I'll just download any of it, or if I talk about district hospital level, so you can download it. Now this is the downloaded sheet. When you will download it at your facility, or the state and district can share it to the facilities. First sheet is about the complete formulas are given, what are the inclusions, what are the exclusions, everything is given in this sheet. Source of data is also mentioned, significance is also mentioned. As you can see, productivity we have total 7, at ARM sub-center we have total 28 indicators for, district hospital we have total 28 key performance indicators. All the indicators in detail are being explained at the first sheet. Now I'm moving to the second sheet, which talks about the values. Here from January till December, we have given the complete here numerator and denominator. But now here the exclusion and inclusion you need to keep in mind when you are putting the value. Suppose in the bed occupancy rate itself, patient bed days, I am putting it to be 300, and functional beds I am putting out to be 200 or 100. You just need to put the value. The staff of your facility just need to put the value against that statement, but keep in mind the inclusion and exclusion criteria. That's it. Then the staff can move it to the final score. Can you see here 10%? I hope my slides, my screen is visible. It is automatically calculated. Whatever the calculation is required, staff needs to just put the value. Then going to the fourth sheet where the graph it shows the graph which shows actually the trend for the entire year. So you can do this for each level of facility. Your facility staff can do it easily. They just need to put the values in the value sheet, and the automatic entire screen will entire graphs as well as the final score will automatically come up. So this is sheet available. Also it is given in this particular. Okay, this is also given in this particular slide. You can always reach out to the NHSRC, your concerned consultant also for this sheet. And if you find any calculation error when you're using the sheet or any difficulty when you're using the sheet, you can definitely get back to us. With this, I would like to, these are the references which I have talked about you, different type of facility, your operational guidelines from where you can learn about different indicators. At the end, I would like to thank you again, emphasize that outcome indicators are your mirror of the quality healthcare. They help us to improve my processes. So by embracing outcome-based measurement, healthcare facilities can transform their performance, enhance patient safety, and achieve excellence in clinical and service delivery. With this, I will end my presentation and I'll just stop sharing the screen. Over to you, Dr. Bhesar.
A very insightful session by Dr. Vanita on measurement of this KPIs and the outcome indicator. Thank you, Dr. Vanita, for this particular thing. Now, I would request each and every one of you. We have already shared the post-training questionnaire and the feedback within in the chat box. It is a request from all of you to please attempt the post-training questionnaire and also provide us the feedback for today's session. For the upcoming webinar sessions, we will be conducting these sessions on 2nd and 4th Thursday of each month, and we will continue to support the states in implementation support for this national quality assurance standards across the level of the facilities. To take up the questions that we got during the sessions, let me invite Mr. Anand Yadav. Anand Yadav is consultant with Quality and Patient Safety Division. He is anchoring the quality assurance activities across the states of Karnataka, Andhra, Andaman, Nicobar, and Chandigarh. So over to you, Anand. Let's have a discussion on the questions that were put up.
Thank you, sir. The first question we got is regarding the, can you explain the Pareto analysis with an example?
Okay. As we said that Pareto analysis is the 80-20 rule. I gave you an example. You can take it in both the manners. 20% of the results are through the 20% of the efforts result in 80% of the effect. In the subsequent sessions, we will be taking each and every tool separately so that you can just you can get an elaboratory overview of how the quality tools will be implemented. So today we just touched upon the overview of the Pareto analysis. Details will be covered in the subsequent sessions in this particularly webinar series.
So next question is, Dr. Pankaj want to know whether 5S is changed to 6S, including safety point also, or it is 5S still.
Okay, so that's an update for us also. Yes, it has been changed to 6S, but under NQAS implementation point of view, we are looking at the 5S methodology that will be evaluated during the time of the assessments in the healthcare facilities.
Next question is regarding Apex committee guidelines.
Oh yeah. Look, this Apex committee, when we are talking about Apex committee will be responsible for the clinical governance. So the expectation is that this Apex clinical committee should be represented by all the HODs of the clinical departments, including your radio diagnosis, and MRD in charge should be the member of this particularly clinical apex committee.
I think Dr. Hina Sheikh has written the labor room table are also considered as a bed. Clarity is required on this.
So, look, when we are talking about this particularly, as Dr. Vinita was saying, when she was explaining the bed occupancy rate, the inclusion and the exclusion criteria, all the beds that are there for the observation on which the admissions are not, taking place in the hospital, these are not counted as the functional beds. Okay, so you are taking as the denominator only on the beds where the admissions are being taken up. So your labor tables, your post-operative ward, the wards in the emergency, these will not be counted at. Your daycare wards will not be counted at. Only the beds on which the admissions are being taken up, they will be taken up as the functional beds.
Next question is from Dr. Hina. We have 200 bedded hospital in corporation. So under which category we will consider this hospital? Under UCSC or SDH?
Okay, so regarding the category of the healthcare facility, it will not be as per the bed availability, it will be the as per the scope of the services that is being provided by that healthcare facility. So if you need any clarity on this particular point, we request you to send us a formal mail so that we can just guide you on which checklist is to be used for this particularly assessment of the healthcare facility. When you are giving us the formal mail, we are expecting that you are giving us the detailed scope of the services that are being provided in that particular facility. We can guide you further on that particular thing.
Okay, so sir, that's all. Dr. Hina Sheikh has also asked regarding the checklist applicability.
So checklist applicability will only be, clarified based, if you can just share us the first scope and then we can define the checklist applicability. I think, Vinita, there is one question for you regarding the dropout rate. I saw that please explain how to calculate the dropout. I think it must be related to your vaccinations or something like that. I request DQA you to please, reframe the question so that we can get the clarity, what is expected. The question says, please explain to calculate dropout. So in the meantime, let's move to the next question. Dr. Pankaj Vats.
If you allow me, sir, may I?
Yeah, please, Vinita. Sorry.
Yeah, so I'm just sharing the sheet again for the dropout rate where it is given in detail. Just give me a minute, please. Yeah, so the dropout rate for pentavalent, basically it is at my PHC level. Here we have clarified that total number of children missed pentavalent 3 dose after pentavalent 1. For that particular month, if you are counting it for the month of January, you need to see how many of the children were eligible for this pentavalent 3. So you need to take this as your denominator. That is your pentavalent 3, how many were the eligible for that particular, then you calculate your dropout rate. So your numerator will be the total number of children received the pentavalent 1, and then your denominator would be your formula would be your pentavalent 1 minus pentavalent 3 into 100 by DPT 1. So this is your formula. The denominator is your pentavalent 1 and your numerator is the total number of children missed the pentavalent 3 dose after pentavalent 1. So basically your questions I am able to understand is for the particular month, because the pentavalent dose was be in the past months. So how you will calculate for that particular month? So whoever will be eligible for that particular third dose of that particular month, you need to take that in your count. For if you go to the values in this also, the facility just needs to put the total number of children received pentavalent. For suppose they 20 children have received pentavalent dose 1 which are eligible for the pentavalent dose 3 in this month, then total number of children missed pentavalent 3 dose. Now you will calculate this, how many are actually suppose 20 were supposed to come for pentavalent 3 but only 10 have come for this particular. So you can just simply put the numbers and it will be definitely calculated by itself. So 50% is your dropout rate, and then you can see the screen your graphical representation. I hope that clarifies it. Over to you, Abhasar.
Okay, thank you, Vinita. Then there is particularly next question is regarding the audit formations, audit findings in the death audit. Look, it has to be, very much clarified over here that audits are being done to improve the efficiencies of the system, be it for the clinical audit, death audits, or the medical audits that we are talking about. The audit findings, if it is asked by the court to share the audit findings, it is the binding on the hospital to share the informations of the death audits as well. But as per the mandate in the healthcare service delivery of India, every death audit has to be, every, maternal death audit has to be conducted. Every neonate death audit has to be conducted. And if such findings are coming up and there, audit, Dr. Pankaj, I just want to clarify, audit is not a blaming game. Okay, it is just to find out the deficiency in all the clinical processes that has happened. But if the information is asked by the court, it is a legal binding on the hospital. You have to share the information with that, but it will not be considered as um, a medical legal case, but it will just be an information that has been shared by the healthcare provider. Okay, Dr. Apurva, regarding the data source, particularly exclusively for the arm centers, the outcome indicator sheets that Dr. Vinita has just shared, which are uploaded on our website. These have the data sources from which the data can be captured, and you can use those data sources for the measurements of the indicators at the Ayushman Arogya Mandir sub-health centers. Regarding the national benchmarkings, look, for the maternal health and for the child health, yes, we have the goals, standard development goals that we are trying to achieve. For other, where the benchmarking is not available, facilities can set its own benchmark based on their initial performance and how they want to proceed and set the targets for the improvement for itself. So that is up to the facility to set the benchmarks. For maternal and child health indicators, the SDG goals are to be considered. These sheets are available on the NHSRC website. You can go to the NHSRC website and access these sheets and can implement these sheets as your facility level. Link, we are sharing the link in the particular chat box. Please use this checklist and try to monitor the indicators to measure the progress. Okay, Dr. Hina, Look, when you are applying for the NQAS certification, it is not mandatorily that you opt for 21 departments. You can apply with the minimum departments that you have, but please, it is a suggestions, and it is a that you, for the monitoring of the quality assurance program, it is mandatory that you take the general administration as the one department, and our core focus area is on for the reproductive and child health. So RM and CHA departments are needed to be covered, and you cannot leave out the accident emergency department, because it serves as the first, a contact point for any emergency patients that are coming to the healthcare. So these are the suggested departments that you need to apply. And whenever your departments are ready, you can apply for those departments during the recertification. Okay, Dr. Vinita, one question is there in the family planning indicator. Is it the permanent methods opted by the clients in numerator, or temporary methods will also be included as a part of the numerator?
I think so both the methods should be included in that.
Okay, so again, we will be, continue with this webinar series. As I said, we will be conducting sessions. Particularly, subsequently, the sessions will be highlighted on this area of concern G and area of concern H. Then further, we will be taking up the other standards as well. And today, this was just an overview of both the area of concerns. In the subsequent sessions, we will go into the implementation details, where you can find all the implementation points right for each level of the facilities. That is the requirement of the National Quality Assurance Standards certification and the implementation part also. So with that, thank you for joining. Again, a request with you all to please submit the post-training questionnaire and the feedback for this particular session, so that we can improve. If you have any queries related to this particular session, the link that we have shared, my email ID and phone number is at that particular details. We have circulated the these letters with the states and the district quality assurance committees. If you have any query regarding any issues, please free to contact us, and we will be happy to help you all in this implementation support. So with that, we are closing this session. But okay, but there is one last moment question. It is related to no. It will depend the conditionalities. It will depend what kind of a conditionality you have got. Because under the certification process, we have a conditionality closure process also, where if the facilities are getting the minor conditionality, and if they can provide the evidences within 3 months that this non-compliances has been closed, facilities can be taken up for the national level of the certification as the conditionality based on the evidence of the conditionality closure. But if the facility has a major conditionality, then the validity is for um, is it 6 months or validity is for 6 months. We are expecting the facility to reapply for the certification within the validity of the conditionality only.
Sir, one more question in QA section. Do we need to conduct prescription audit, death audit need in department wise?
No, it is not mandatory. As I said, prescription audit is a monthly activity or a quarterly activity that the facility can undertake. For every maternal death, for every neonatal death, it is mandatory to undertake the death audit. Then it is up to the clinical apex committee that has been framed in the under this clinical governance framework that can decide its own schedule of conducting the death audits. It can be taken up on the quarterly or the biannually basis also. If it is a minor conditionality, there is no need to undergo a physical inspection if you provide the detailed evidences that the conditionality has been closed. But for the major conditionality, if you are then the physical inspection will be done to verify that particularly non-compliance closure. So with that, thank you. Thank you for joining in, and we request you all to please circulate the links. For the link will remain the same for all the webinar sessions. We request you all to again join us on second and fourth Thursday of every month, and we will be providing detailed guidance on implementation of these standards at the facility level. Again, a request to please submit this post-training questionnaire and the feedback that the link we have shared. So with that, I would like to thanks Dr. Vinita, Mr. Anand, and all the participants that have joined. And let's work collectively for the implementation of these standards across the level of the facilities so that we can proudly provide the quality of the care to the end beneficiaries that our country needs. Okay, so thank you and a very good afternoon. Jai Hind.